Welcome to the Radiographics Podcast. I'm Ross Frederick. This week on the podcast, I will be discussing epidural injections of the cervical and lumbar spine, and Dr. Gibbs will be talking about non Hodgkin lymphoma in children and young adults. Fluoroscopically guided epidural injections of the cervical and lumbar spine. Chronic spinal pain is not a life-threatening condition, but can cause profound disabilities in physical and psychologic health. Because of the growing prevalence of spinal pain and technical advances in treatment, non-surgical interventions for spinal pain have rapidly increased. Epidural steroid injection has become one of the most commonly used interventions for spinal pain. Epidural steroid injections deliver drugs directly into the epidural space under fluoroscopic guidance, CT guidance, or using a combined approach, and relieves pain originating from degenerative spine disorders or disc herniations for a relatively short time. This article reviews the anatomy of the spinal epidural space, suggests methods for selecting the proper approach according to different clinical or imaging features, and describes the technical details of epidural steroid injections and its complications. The epidural space is the space located inside the vertebral spinal canal and outside the dural sac, and it extends from the foramen magnum to the sacrohiatus. The epidural space is bordered by the ligamentum flavum and periosteum posteriorly, and the posterior longitudinal ligament and vertebral body anteriorly, and the pedicles and intervertebral foramina laterally. The epidural space commonly contains fat, venous plexus, spinal branches of the segmental arteries, and lymphatics. Fat is the major component of the epidural space and is the key factor in epidural steroid injections because it allows injected lipophilic medication to stay in the epidural space for a long period for sustained action. The nerve roots from the spinal cord pass through the epidural space before they exit the spinal canal through the intervertebral foramina. It is essential to confirm whether a patient's pain is concordant with findings at MRI or CT before epidural steroid injections are performed. Radicular pain associated with disc herniation or foraminal stenosis usually follows the affected nerve root distribution, which could result in motor weakness as well as sensory changes. Spinal stenosis causes neurogenic claudication and sciatica, which improve with forward flexion, whereas axial low back pain is aggravated with forward flexion. General indications for epidural steroid injections include herniated disc disease with or without radicular pain, spinal stenosis, axial low back pain, and post-lumbar surgery syndrome. Whereas there is robust evidence for epidural steroid injection efficacy in treatment of radicular pain associated with disc herniation, considerable controversy surrounds the use of these injections in patients with spinal stenosis, non-radicular discogenic back pain, or postoperative spinal pain. When performing the injection, the basic principle is to select the approach closest to the source of the pain. For a lateralized herniated disc at the lumbar level, a transforaminal injection is preferred over a paramidline interlaminar injection. However, in the cervical spine, an interlaminar midline or paramidline injection is the option of choice, irrespective of disease categories or laterality of symptoms, because an interlaminar approach is safer and more comfortable for patients, and a cervical transforaminal injection has potential risk for serious complications, including cerebellar and spinal cord infarction. When considering an epidural steroid injection, several pre-existing conditions should be checked to avoid complications. These conditions include coagulopathy or concurrent anticoagulation therapy, systemic infection, local skin infection at the puncture site, hypersensitivity to administered agents, and pregnancy. This is a Category 2 procedure, meaning moderate risk of bleeding, so INR should be greater than 1.5 and platelets greater than 50. Steroids and local anesthesia are generally used in combination for anti-inflammatory and analgesic effects. The steroid reduces nerve swelling and upregulates the transcription of anti-inflammatory genes, in contrast to local analgesics, which are responsible for immediate pain relief. The choice of steroid formula is a recent issue in epidural steroid injections. Particulate steroids may be responsible for spinal cord infarction or cerebellar infarction after injection, presumably due to particle embolization. Particulate steroids are thought to work as emboli if there is inadvertent puncture of small arteries that supply the spinal cord or brain. Dexamethasone sodium phosphate, which is non-particulate, is considered safe. A cervical interlaminar injection is usually performed by using the C6-C7 or C7-T1 interlaminar spaces, where the epidural fat is more adequate. After confirming the puncture site on AP and lateral views of the cervical spine, it is recommended that the skin puncture be started with use of the AP view, with caudal angulation of the current tube to see the interlaminar space en face. The needle is then advanced just ventral to the spinal laminar line with use of the lateral view. The cervical epidural space is only 1 to 2 millimeters in width. It is important to be cautious and to use a small test dose of contrast injected intermittently while the needle is traversing the spinal laminar line. When the needle tip arrives at the true epidural space, just ventral to the spinal laminar line, contrast agent flows dorsally along the spinal laminar line. With an interlaminar injection, a single line and well-defined or smudged convexity along the spinal laminar line on the lateral view suggests that the needle tip is positioned correctly in the epidural space. On the AP view, contrast dispersion may outline exiting spinal nerves. A cervical transforaminal injection is performed in the supine position by using an oblique anterior approach because the cervical neuroforamina are aligned according to an axis oriented 45 degrees anteriorly. The obliquity of the current tube, approximately 45 degrees towards the symptomatic side, allows the intervertebral foramina to enlarge. After tilting the current tube to the angle at which the foramen is the most enlarged, a needle is advanced parallel to the C-arm beam, targeting the posterior aspect of the foramen, with contact to the superior articular process of the lower cervical spine segment. Then, returning to AP view, the needle tip is cautiously advanced further to the lateral third of the lateral mass. Lumbar intralaminar injection uses the same basic approach as in the C-spine. The needle is advanced just ventral to the spinal laminar line, seen on the lateral view. To confirm arrival at the epidural space, a test dose of contrast agent is injected. When the ligamentum flavum is thick, the tip of the needle may enter deep into the spinal laminar line. The loss of resistance as the needle traverses the ligamentum flavum, which indicates that the needle is in the epidural space, can be unreliable, compared with use of test injections of contrast. A test injection of contrast would result in a vertical semilunar shaped contrast deposit along the spinal laminar line on the lateral view. The paramidline approach is preferred when a midline approach is difficult, as in cases with ossification of the supraspinous ligament or Bastrop disease. For a lumbar transforaminal injection, the current tube is tilted cranially or caudally until the superior end plate appears as a straight line, and the tube is then rotated ipsilaterally at an oblique angle, 10 to 30 degrees, which reveals a typical Scotty dog appearance. Different approaches are possible: a classic subpedicular approach and a posterolateral retroneural approach. The classic subpedicular approach targets a safe triangle in the anterior superior third of the neural foramen. By using this approach, drugs can be delivered into the anterior epidural space, which is usually a location closest to neural compression by a herniated disc, and the needle tip tends to be placed at the lateral half of the foramen as seen on the AP view, with minimal risk for dural puncture. In the posterolateral retroneural approach, the needle targets posterior to the nerve root just after penetrating the circumneural sheath and delivers drugs from the posterolateral corner of the epidural space to the lesion. The advantages of the posterolateral approach are less chance of nerve root irritation and less chance of vascular injury. For the posterolateral retroneural approach, the needle is inserted just lateral to the superior articular process or the pars interarticularis on the oblique 10 to 30 degree view. On the lateral view, the needle tip is advanced with intermittent injection of contrast until it spreads between the circumneural sheath and the nerve root. The needle tip should not be advanced into the anterior third of the neuroforamen on the lateral view, and it should not be advanced beyond the mid-pedicular line at the 6 o'clock position on the AP view. Let's cover some of the pitfalls of epidural steroid injections. Contrast staining of the paravertebral soft tissue, ligaments, or muscles in the course of needle advancement can occur if contrast is injected before entering the epidural space. This paravertebral muscular or ligamentous staining appears parallel to the course of the muscle fiber or ligament. The so-called false staining is usually located posterior to the spinal laminar line. Therefore, it is easy to distinguish from true epidural space staining. Intravascular injection is a common pitfall in epidural injections. Intravascular contrast flows in a configuration of curvilinear or thin straight lines and disappears at the moment of injection without accumulation. If intravascular flow is observed, the needle is withdrawn sufficiently and repositioned, targeting different locations. Dural puncture during epidural injection is a common and critical condition with a reported incidence of up to 5%. Complications of dural puncture include post-dural puncture headache, paresthesia, intracranial hemorrhage, Cauda-Equina syndrome, aseptic meningitis, and arachnoiditis. Post-dural puncture headache is caused by CSF leakage through the puncture site, which results in low intracranial pressure. It usually develops within 5 days after dural puncture and typically manifests as a postural headache that worsens while sitting or standing and improves after lying down. With an intradural injection, contrast material rapidly disperses and accumulates at the ventral portion of the spinal canal, forming a CSF contrast level with dorsal CSF fluid and ventral contrast because of the patient's prone position. The AP view demonstrates a symmetric distribution of contrast, similar to that seen at myelography. Unintended intradural injection of local anesthetics acts as an intrathecal anesthesia equivalent and can cause sensory deficits. Intradural injection of local anesthetics into the high spinal cord level can cause fatal complications such as respiratory failure. Therefore, local anesthetics must be excluded from cervical epidural injection. Subdural injection is another pitfall. The contrast trap between the dura and arachnoid matter can have a tubular blotchy appearance. It often spreads up and down the dural sheath, manifesting with fine vertical parallel lines that demarcate the inner surface of the dura. A final pitfall is nerve injection, in which contrast fills the intraepineural space. This manifests as two thin lines resembling a tram track with a subtle feathery appearance inside the nerve root and sharp outlines. Let us recap. General indications for epidural steroid injection include herniated disc disease with or without radicular pain, spinal stenosis, axial low back pain, and post-lumbar spinal surgery syndrome. With an interlaminar epidural steroid injection, a single line and a well-defined or smudged convexity along the spinolaminar line on the lateral view suggests that the needle tip is positioned correctly in the epidural space. On the AP view, contrast agent dispersion with drug injection may outline exiting spinal nerves. With a transforaminal epidural steroid injection, if the needle tip is in the true epidural space, a test dose of contrast will usually flow upward along the medial margin of the pedicles and along the exiting nerve. With an intradural injection, contrast material rapidly disperses and accumulates at the ventral portion of the spinal canal, forming a CSF contrast agent level because of the patient's prone position. The AP view demonstrates a symmetric distribution of contrast, similar to that seen on myelography. Now let's hear from the one and only Dr. Gibbs about non Hodgkin lymphoma in children and young adults.
Non Hodgkin lymphoma, imaging spectrum in children, adolescents, and young adults. Non Hodgkin lymphoma is a heterogeneous group of lymphoid neoplasms and 7% of all malignancies that develop in individuals younger than 20. Age is an important classifier in NHL, as each age group has a distinctive biology, as well as differences in distribution, histologic subtype, clinical presentation, natural history, staging system, prognosis, and survival. Children aged 0 to 14 are considered the pre-adolescent group, whereas individuals between 15 and 39 are considered the adolescent and young adult group. Imaging plays a crucial role in the diagnosis, staging, and follow-up of NHL, which may be challenging given the predominantly extranodal origin and the overlap with other diseases. Here the authors discuss the epidemiology, classification, clinical findings, imaging spectrum differential diagnoses, and challenging scenarios of NHL in children, adolescents, and young adults. The incidence of NHL increases with age, ranging from 6 per million in children younger than 5 to 150 per million in adults. The exact cause of NHL is unknown for most patients. There's an increased incidence with some congenital or acquired immunodeficiency states, such as after solid organ transplant or HIV infection. Secondary NHL tends to arise 10 to 12 years after successful treatment of leukemia and Hodgkin lymphoma. Unlike the low-grade lymphomas that predominate in adults, The majority of childhood NHLs are aggressive. The main pathologic subtypes of NHL in children and young adults are Burkitt and Burkitt-like lymphomas, lymphoblastic lymphoma, diffuse large B-cell lymphoma, and anaplastic large cell lymphoma. NHL can affect any tissue, and because of the substantial clinical and imaging overlap with inflammatory, benign, and other malignant conditions, it continues to represent a diagnostic challenge. Extranodal NHL prevails in children and adolescents compared with adults. B symptoms are relatively uncommon. Owing to the rapid growth of some subtypes of NHL, acute presentations can occur, including intestinal obstruction from intussusception, external compression of the tracheobronchial tract or superior vena cava by mediastinal masses, or cardiorespiratory compromise from large pleural or pericardial effusions. Diagnosing NHL requires tissue biopsy and imaging to evaluate the disease extent, determine prognosis, and choose treatment. Although PET-CT is not routinely performed for NHL staging in children and young adults, it does add to the anatomic information provided by CT, with the functional information about the metabolic burden of disease. As a possible alternative, whole-body MRI is a radiation-free way to depict soft tissue with good anatomic detail. In literature, it's been shown that whole-body MRI with STIR can help in pediatric lymphoma staging, with very good agreement between whole-body MRI compared with FDG PET. MRI can accurately depict nodal and extranodal disease and monitor indolent NHL and NHL in complete remission. Diffusion-weighted imaging is another technique that's evolved for superior disease contrast with background body signal suppression, and grayscale inversion of DWI can produce images that resemble PET images. There's a nice table in the paper describing the pros and cons of different modalities. PET does seem the best aside from the radiation. This paper details disease and imaging characteristics in each of the body systems and parts, so take a look at that. I'm going to jump ahead to the potentially life-threatening conditions in children and young adults, which can happen at any time of the disease course. Prompt diagnosis and treatment are crucial to achieve favorable outcomes. Let's start with large mediastinal mass. A large mediastinal mass can cause airway compromise from tracheobronchial compression, which can be assessed with chest radiographs or CT. Cardiovascular involvement is less common and may compress the SVC, leading to SVC syndrome. Administering anesthesia during imaging or biopsy becomes challenging, as tracheal narrowing is exaggerated in the supine position, owing to the combined effect of gravity, the weight of the mediastinal mass, and increased intrapleural pressure. Positional modification for CT, for example, the child lying on their side, and biopsy, maybe upright position, with local or minimal anesthesia may be required. SVC syndrome, with its classic signs and symptoms, occurs owing to impaired venous drainage of blood from the head and neck. Mediastinal widening and hilar prominence are the most frequent findings on chest radiographs. Intravenous contrast-enhanced CT of the chest is the imaging modality of choice for diagnosis to evaluate the cause of SVC obstruction and the extent of collateral formation. On CT, an area of intense focal wedge-shaped enhancement of the quadrate lobe of the liver in the arterial and venous phases is known as the hot quadrate or hot spot sign. Boy, I'd forgotten that. Which is due to portosystemic venous shunting between the SVC and the left portal vein through the internal mammary and perumbilical veins along the ligamentum teres, which may be seen secondary to SVC obstruction. How about bowel obstruction and perforation? Intussusception in children older than 4 years should raise suspicion for a pathologic lead point such as a Burkitt lymphoma. Ultrasound is the primary imaging modality for identifying this. In such patients, enema reduction is frequently unsuccessful and may cause complications including bowel perforation. Massive pericardial effusion and cardiac tamponade. The causes of pericardial effusion can range from lymphomatous infiltration or heart failure to a side effect of chemotherapy, radiation therapy, or hematopoietic stem cell transplant. Chest radiographic findings include an enlarged cardiac silhouette. CT can show compression of the cardiac chambers as a result of massive pericardial effusion or a huge mediastinal mass that may lead to cardiac tamponade. Urgent pericardiocentesis may be needed. Neurologic cord compression and cauda equina syndrome. Compression of the spinal cord is infrequent but can happen in patients with NHL, and early diagnosis and therapy are necessary. Patients with external compression by a paravertebral tumor commonly present with back pain and/or irreversible neurologic damage. MRI is the technique of choice for assessment of the entire neuroaxis. Now, the authors also talk about challenging scenarios radiologists may face in these cases. Lung nodules and general anesthesia-induced atelectasis. Atelectasis in the dependent lung lobe starts within 5 minutes of induction of general anesthesia, which decreases the possibility of accurately interpreting thoracic imaging for lung nodules. Similarly, underinflated lung segments may necessitate patient repositioning, risking endotracheal tube or mask dislodgement. Use of standardized protocol for controlled ventilation may reduce dependent atelectasis during image acquisition. Rebound thymic hyperplasia. Increased thymic size compared with that on prior CT exams after complete remission following chemotherapy can potentially be mistaken for relapse. Various imaging criteria exist to suggest rebound thymic hyperplasia, including homogeneity and flexibility with breathing on ultrasound exam, the absence of mass effect on CT and MRI, and regrowth of 50% of thymic volume following chemotherapy. Granulocyte colony stimulating factor administration. Diffuse increase of the bone marrow and spleen FDG uptake can be seen during GCSF treatment, reflecting hematopoiesis activation. FDG uptake can persist for up to 3 weeks after the discontinuation of GCSF treatment. Accordingly, it's recommended to postpone PET-CT until around 4 weeks after treatment. Osteonecrosis. Although rare, osteonecrosis as a result of chemotherapy or corticosteroid treatment may be seen about 2 years after initiation of therapy, with median interval of about 25 months. On PET-CT, osteonecrosis appears as a hypermetabolic bone focus and may mimic active disease. Osteonecrosis should be suspected in new hypermetabolic bone foci when primary tumors have shown a good response. Altered biodistribution of FDG on PET. High doses of steroids used in NHL treatment may cause increased FDG uptake of the superficial facial tissue and the subcutaneous fat of the shoulder girdle and trunk. At the same time, the normal hepatic FDG distribution, as well as the FDG avid NHL mass, may be suppressed. Radiologists and nuclear medicine physicians should exercise caution while interpreting the PET-CT exams because of the altered tracer biodistribution. Another interesting topic that the authors briefly address is toxic effect of immunotherapy. Immune-based treatment strategies, including checkpoint inhibitors and chimeric antigen receptor T cells, have been a great advance in the treatment of refractory or relapsed NHL, as we've talked about on prior podcasts. Chimeric antigen receptor T cells are genetically modified T cells that produce an immune response against NHL and are currently used in clinical trials. Unfortunately, this newer treatment is associated with high risk of toxicity, such as cytokine release syndrome and neurotoxicity within 1 to 5 days of treatment initiation. The incidence of neurotoxicity in pediatric and young adult populations is similar to that in adults, about 45%. On MR images, a nonspecific pattern of predominantly white matter involvement extending to the brainstem is often seen. So that's just the highlights from this article. There's a lot more here, so take a look. In conclusion, knowledge of the imaging spectrum of NHL in children and young adults is critical for diagnosis, staging, and assessment of treatment response. The appropriate recommendation of conventional and advanced imaging modalities based on their utility and limitations in specific clinical contexts can provide invaluable guidance to oncology teams for the provision of care. There's an opportunity for collaboration between pediatric and adult centers to further study the clinical pathologic and imaging features of NHL in the adolescent and young adult population to define best practices and improve outcomes.
All right, that's it for this week's podcast. Check out these articles in the newest issue, online or in print. We'll be back in 2 weeks for more summaries.